Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everyone. I'm Ara Christian, coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harbor, UCLA, we're excited to welcome you to another highly anticipated edition of our AABIP webinar series. We're proud to bring you the latest and greatest, and today is no exception. But before the formal introduction of today's topic and speaker, I'd like to review a few housekeeping matters. First, everyone please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and be found under the Education and Training tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and optimize the overall listening experience for everybody. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on the thought bubble icon located in the bottom left of the iMeet window. Now, we will keep track of the questions as they come up and have the opportunity to address them toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time. Also, on the bottom left is the projector icon. This allows the audience to toggle between the presenter slides and any videos. I don't believe we have any videos today. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shaw for our formal introductions today. Dave?
Thank you, Ara. Today we are very fortunate to have Dr. Scott Ferguson joining us from the University of Wisconsin in Madison. He is going to be talking to us about clinicogenomics and risk stratification of lung nodules. You may know Dr. Ferguson from his roles as the Director of Interventional Pulmonology over at the University of Wisconsin, as well as being the Program Director of their IP Fellowship Program over there. So thank you very much for joining us today, Scott. I'll go ahead and turn this time over to you.
Thank you, David, and it's really a pleasure to be invited and to speak to the audience here about this subject. I think this is a very interesting subject that I know a little bit about, but I know that there are many people who probably know quite a bit more than I do, and so I'm always willing to hear back from audience members about their experience with this. Any talk is going to be one where things are not perfect, but we'll go through the way that I see this, and then hopefully have a chance to do some question and answer at the end. So clinical genomics and risk stratification of lung nodules, and just pointing out this is a photograph from the Mendota Lake looking at Madison. It's a very beautiful city, and if you have a chance to visit sometime, we'll take you out on the lake and show you how you do it in the Midwest here. So we'll get started now. So my conflicts, which I think are important to point out, is that I'm an investigator, scientific advisory panel member and consultant for the AEGIS I and II trials, and that was under the company called Allegro Diagnostics. That company was purchased by Veracyte, where I'm a scientific advisory panel member, consultant and investigator for them as well, for some of the technology that we'll be talking about. So this is the problem. So we have many patients in our clinics, if you do clinics like I do, who come in with lung nodules that they're very worried about. And I don't know if you're like I am, but I'm never 100% comfortable with what I am telling patients every time. I try to be as honest as I can with them. I try to work through the way that my mind thinks about this problem and try to get to a mutually agreeable solution for the patient. And here's a patient who's a relatively young woman, 40 years old, a little bit of smoking in the past and has a lung nodule, and she's terrified that this is lung cancer. And I don't think it's lung cancer, but she's worried, and because of that, I think we have to figure out what the right answers are for her. And this brings up the lung cancer paradox. And so the lung cancer paradox says that we can detect lung cancers relatively early like this one, but we don't really diagnose them often until they're much more advanced than that. And that's what we're all trying to improve as we go forward with our practices in interventional pulmonology, lung cancer, and pulmonology. So this is really the problem. So it's estimated now that there will be greater than 234,000 new cases of lung cancer and 154,000 deaths due to lung cancer in the U.S. in 2018. Many people are being discovered with nodules, about 1.5 million individuals each year. 8 million people in the U.S. Currently meet eligibility for low-dose CT lung cancer screening. That's a huge number of individuals to screen. With respect to lung cancer and testing, false positive nodules dominate, and this was something that I had to learn over and over again in looking at lung nodules, which, as a fellow, I would look at a lung nodule and everything was a cancer, and I had to learn a new way of thinking about it. Risk stratification is essential in evaluation, and so this is where the clinical world meets the technological world, and how do we manage these multiple different tests that we're using to evaluate our patients. So the differential diagnosis, as all of you know, is between benign and malignant. And most patients don't really care about the benign disease, but they care about the malignant. But it's always good to remember that, especially in a place in an area like the Midwest and some other areas, that infections are relatively common. In Madison, we see a lot of histoplasmosis nodules. And we see a lot of sarcoidosis, some vasculitis, occasionally cysts, endometriosis, lipomas. There can be quite a few different things that can cause a benign lung nodule. And whenever I have a patient in my clinic, I say, the averages for just coming to my clinic are relatively good, that this is going to be a benign process, but we have to go through the process of figuring that out. So current methods of risk stratification include many patient factors, and these are things that we're fairly familiar with, such as age and smoking, radon exposure, the occupation, where patients live, environmental tobacco smoke, HIV and other forms of immunosuppression, family history, and there can be many others. We put all of this clinical information together in our evaluation of patients, and hopefully we're able to sort out some of those important nodules from those that are less important. Nodule and mass factors are also important, such as the size of the lesion, the edge characteristics, calcification, the density, and location. And so many of us are pretty used to doing this kind of work in our clinics, and we all know that that as a clinician we can use these characteristics, and we can get to some pretty good risks of lung nodules being malignant, but we're not perfect by any means. Now, any talk about nodules is going to include NLST in the National Lung Screening Trial. I imagine many people in the audience are thinking, oh God, is he going to go over this kind of stuff again? We've heard so much about it. And I put this in primarily as a way to demonstrate that the NLST taught us a lot about lung nodules and taught us a lot about the harms that occur from some of the testing that we do in individuals. So as we know, this was to compare low-dose CT CT to chest X-ray for lung cancer screening. It was in individuals who had a elevated risk for lung cancer. A lot of patients, 54,000 subjects, and they did 3 annual screens. The average radiation dose was low, 1.5 millisieverts, and then some guidelines were developed for diagnostic follow-up. This is some of the results, and what I'm pointing out here with the boxes around some of these is how many of the individuals had no lung cancer confirmed, and that was obviously the majority. It was 96%, 94%, et cetera, of the individuals screened did not ever get a confirmation of lung cancer. But many of those individuals underwent invasive testing. And so in a lot of what I may be talking about today is I'm focusing on who are the individuals that don't have lung cancer and how can we minimize some of these harms. So many had undergone either percutaneous biopsies, bronchoscopy, or surgical procedures, and were not found to have lung cancer. 25% of the nodules that were removed in NLST were benign, and in those individuals who did not have lung cancer confirmed, there were complications, as well as in those who did have lung cancer. The rate of death within 60 days after the most invasive diagnostic procedure was relatively low, 10 in the lung cancer confirmed group and 11 in the lung cancer not confirmed group. But in individuals who don't have a malignancy, are we satisfied with even that low rate of death after that invasive test in something that may have been a benign nodule? This is the positive data of NLST. And NLST shows us, or showed us that that we could affect mortality from lung cancer. And this is what tells us, we need to keep doing screening. We need to find better ways to do screening, probably, and we need to find ways to protect those who don't have cancer or have benign nodules. So, so I think that all of us are relatively familiar with that, but what's, I think, most illustrative of the problem at hand is that lung nodules are common, and many of them are not, or most of them are not cancers. So how do we make screening and nodule management better? So we can do standardized radiology interpretations. We'll talk a little bit about that. We should all be doing evidence-based evaluations as those are becoming more and more common. I'm a big proponent of multidisciplinary care. I don't think any of us own the lung nodule patient, but many pulmonologists treat patients who have lung nodules. And the way that I see a lung nodule is very different than the way that our surgeons see lung nodules, and different than the oncologists, and different than the radiologists. And I think when you get all of those disciplines involved in evaluating lung nodules, I think that we can get to better outcomes. And so I would encourage you, if you have the capacity to have multidisciplinary groups, at least multidisciplinary groups looking at some of the imaging with you. We need to be really big proponents of smoking cessation because that's going to reduce mortality from lung cancer. We need to look at clinical predictors like some of the ones that we had just gone over, and then we'll be talking about clinicogenomic predictors here in a little bit. So these are ways to make some of it better. So lung RADS was introduced a few years ago, and this is to standardize the method of reporting to improve communication, reduce variability, and stratify risk. This helps provides follow-up suggestion and reduces false positive screens. And the way that the lung RADS, if you haven't seen it, is laid out is that everything receives a number and some a letter, and then and that corresponds to 1, like no nodule, return to screening, and 6, malignant by pathologic criteria. And I'll point out again that lung RADS is used is used exclusively for the screening population. This has not been validated in incidental nodule discovery. So if you have a screening program at your institution, your radiologist should be reporting that out in the lung RADS fashion. Fleischner Society, this is for incidentally discovered nodules. The new guidelines that came out in 2017 are comprehensive and very well thought out, in my opinion. I think that the most important part of the Fleischner Society guidelines that distinguishes it from other guidelines in the past is that clinical judgment really drives the guidelines here. And I think that that's extremely important whenever we're evaluating these patients, is to, we've got to match the nodules with the patients, and that's a better way of figuring out what is the risk to the person, and what do they want? You know, what is their value system as you're evaluating these patients with nodules. So clinical judgment drives guidelines, and I think that that's extremely important. The other thing that radiologists remind us is that we should all be reviewing the axial, coronal, and sagittal imaging. This image from RSNA shows what appears to be a nodule here on the right side, but if you look at it on the coronal, it's a flat fissure-associated, probably scar or lymphoid tissue, and not a true nodule. So teach your fellows to review all of those, axial, coronal, and sagittal on every patient with a lung nodule, and we can get our own interpretations much better. Strategies that many of us use, just to mention briefly, serial radiographic follow-up in selected patients is much of what I do. Sometimes I use PET scanning if the clinical information and the radiographic information are discordant, although I'm not a big proponent of using PET scanning. I think that it's clearly much better in staging evaluations. I find it to be often less helpful in evaluation of lung nodules. For high-risk nodules, we often refer patients to surgery, and this is still a very valid pathway to go for those who you think have a high risk for lung cancer. Many patients can't tolerate surgery, and so we have to sometimes do other things even though they're high risk. Moderate risk, we often will do biopsies in those individuals. So this is individuals with a risk somewhere between 5 and 10% up to about 65% is moderate risk. Low risk, so less than 10%, less than 5 or 10% depending on the author, often is radiographic follow-up. You determine the best course of your evaluation by involving your patient. So some low-risk patients may not be appropriate for radiographic follow-up simply because of patient factors. So many patients are very unsettled and with a lung nodule, and sometimes we have to offer them something more than simple radiographic follow-up in order to prove that their nodule is benign. However, some of those individuals who we judge as low risk are going to have lung cancer, and so we have to be aware that that's a possibility. Nodule size and growth is the main thing that we use for determining the risk of malignancy. And small nodules are very unlikely to be malignant, and big nodules are likely to be malignant. If you have a very slowly growing nodule, those are very likely to be malignant. So sometimes if we get a person into that radiographic follow-up period, we'll look at their growth rate, we'll look at the overall size, and then each time they visit, we have another conversation with them about what we think is going on and what we should be doing. Spiculated nodules, as we all know, are much more likely to be malignant, and lobulated edges. Cavitation with thick walls is a strong predictor of malignancy. And if you look at McWilliams' data from New England Journal of Medicine in 2013, where they reported on the PanCan study and BCCA. So PanCan had 2,500 subjects, and 5.5% were malignant. The British Columbia Cancer Agency, 1,090 subjects, and 3.7% were malignant. So again, showing that malignancy in the screening population is still the minority. So still the minority are malignant. What they found was that the probability of malignancy in these individuals was significantly associated with female sex, nodule size, upper lobe location, spiculation, older age, family history, emphysema, lower nodule count, and part solid. So that's a very good paper that if you haven't not reviewed that before, it's very good to review and teaches us all a lot about screening and about nodule assessment. So I have a case study for you because I think this can illustrate a few things about what I've been talking about and what I'm going to talk about. But I have a patient, this is a real patient, 81-year-old man, former smoker. He smoked maybe a half pack a day in college. He had a nodule discovered after a yearly physical. He was a former teacher in the Midwest. He's retired. He had had a pacemaker placed for bradycardia, but otherwise was healthy, enjoying retirement. And this is a CT scan, and what you can see is a spiculated nodule in an upper lobe on the left. It's about 1.5 centimeters in diameter, and he wants to know what should be done. So what would you do? The choices here are a CT-guided transthoracic needle aspiration, video-assisted thoracic surgery, bronchoscopy, empiric SBRT, or radiographic follow-up. And you can actually type your answer into the texting window or the conversation window, and we'll see what everybody thinks. Now, for those of you who are a little bit shy about putting in what you think may be going on or what you think is the right thing to do, I think you can make a case for all of these things depending on the clinical scenario. So don't be shy about stuff. Just add in there what you would do, and I'll tell you in a few minutes as we go forward in the talk. So what we really want to do in any kind of nodule evaluation and any kind of screening evaluation, when we know that the majority of what we see are going to be benign nodules, how do we reduce the harms of the things that we use in order to investigate those? Now, I'm going to talk about 3 of these, but there are several different things that are available, at least by investigation. And some that are FDA classified or FDA approved. I'm going to talk to you about the Bronchial Genomic Classifier, the Nasal Genomic Classifier, and blood genomic classifiers that are some approved and some in study at this point in time. There are others that are out there: protein expression profiles, elastography, electrical conductivity. I'm not going to talk about those, but there is some literature on those out there for your perusal. So what makes an ideal biomarker? So an ideal biomarker needs to be accurate. It needs to be easy to use, so easy to collect. It should be timely. We should be able to get results within a reasonable time frame, and it has to have clinical utility. For screening, that means it can help identify those who would be most likely to benefit from screening and those that are unlikely to benefit. For nodule evaluation, helps diagnose lung cancer early or reduces patient exposure to invasive testing when lung nodules are benign. And this is laid out very nicely in a position paper by the ATS, first authors Maison, and in the American Journal of Respiratory Critical Care Medicine from 2017. And I would encourage you to get that position paper and have a look at it, as it explains a lot about what is necessary. So in developing a biomarker, you have to go through a discovery phase. So somebody has to discover their test or what they think may be a good test for their biomarker. Has to go through analytical validation, just making sure that the techniques and the methods are correct and that they are consistent. Clinical validation, so meaning that it can help you identify the disease in question. And then it has to have clinical utility. And by clinical utility, we mean that it has to influence and help the clinicians and patients determine what to do next. So it's no good. So you can have great discovery, fantastic analytical validation, fantastic clinical validation, but if it doesn't have clinical utility, it's worthless. It's essential that we identify the intended use population. So is this test best for the screening population? Is this test best for the incidental nodule population? It must help with clinician judgment, and we have to have a strategy of use. So how are we going to strategize using this test for our patients? Just curious how the marks are showing up on my slides, David or Ara?
Looks like a little bit like graffiti.
Okay. So I don't think I'm doing that, but we can move forward. Okay. So the Bronchial Genomic Classifier is the biomarker that I have the most experience with. So this was developed and initially reported by Avi Spira's group in Nature Medicine in 2007. And what they observed was that smokers develop a field of injury in the airway epithelium, and that has been shown to induce genetic changes apart from cellular atypia. So in other words, if you have a smoker and you look at their airways and you do a biopsy or a brushing and you look at the cells under the microscope, those cells are all normal, but you can find genetic changes that are unique to that individual who's a smoker compared to those who don't smoke. They developed the hypothesis that individual smokers could respond differently to the smoke, giving rise to this differential gene expression with and without lung cancer. And so what they did is they took individuals with and without lung cancer, and they used microarrays to probe gene expression from cytologically normal airway epithelia with and without the cancer, and to develop a classifier. This is just a schematic of their discovery and validation, where they took 129 individuals, some with and without cancer. They took some of those through a test set and a training set in order to identify the genes that were associated with cancer versus the genes that were not. So the microarray is a very broad-based way of looking at different genetic signatures, and what they found was they developed an 80-gene predictor, so 80 different genes all combined together that were good at predicting the presence of lung cancer in individuals who had it. The receiver operating curve looks very nice. This is a very good receiver operating curve for the sensitivity and specificity for this gene predictor. So they went on to there we go. So they did further derivation. They took 299 subjects, 223 had cancer. They prospectively collected normal appearing bronchial cells. They isolated RNA and performed microarrays, and they ended up paring that down to a 17-gene classifier with the receiver operating curve area under the curve of 0.81, indicating that this is a very good test with the 17 genes, and this was done then by PCR, so it made it much more obtainable than using microarrays all the time. You could do the PCR to look for the 17-gene classifier, and then that would help with test development. So Then they developed the AEGIS I and II trials. And in AEGIS I and II, they had a prospective multi-center study of patients undergoing bronchoscopy with a suspicion of lung cancer. So these are individuals who had a nodule or a mass, and we thought that there was at least some risk that an individual had cancer. We decided to take them through bronchoscopy as the test of choice in order to try and diagnose the lung cancer. And during that bronchoscopy, we collected the epithelial cells from the right main stem bronchus, or if the right main stem bronchus appeared to be involved in cancer, then we use the left main stem bronchus. 639 patients. Out of 639 patients, 42% of the bronchoscopies were not diagnostic for lung cancer. And so they then took the negative likelihood ratios of a negative bronchial genomic classifier to look at what threshold of pretest probability of cancer would be required to keep the risk below 10%. So let me say that in a different way, because this is sometimes hard to wrap your head around. What they discovered that they probably had with this test is likely to be a rule-out test. So what they asked was, could we use this test to reclassify patients with a risk for cancer down to a lower risk for cancer using the biomarker? So so as you get higher and higher with your pretest probability of cancer, the ability for the test to rule it out becomes much less. So if you use a negative test, then what is going to keep that post-test probability below 10%? That's that dotted line here. So below 10%, it appears that if your pretest probability gets up to around 60%, that seems to be the threshold. Above 60%, the negative classifier doesn't do anything in order to help with your management of your patient. But if your pretest probability is below 60%, a negative classifier, then even if you had judged the risk to be 50%, a negative classifier would drop that down to 10% or below. So this is the data, and what I'll point out is that in this data, they found that they had a very high sensitivity for the presence of lung cancer. So if you combine the classifier and bronchoscopy, the sensitivity for intermediate risk, so these are predetermined patients. So I see a patient in the clinic, I think, okay, you've got an intermediate pretest probability of lung cancer. If I use the classifier and bronchoscopy, there's a 93% sensitivity for the presence of cancer. If you have a low pretest probability of cancer, the combined classifier and bronchoscopy was 100%. And if you have a high pretest probability of cancer, it was 98%. However, the negative predictive value was slightly different because of the prevalence of the disease in the population. And it appears that in the negative predictive value question, it operates very well up to the intermediate pretest probability, so a negative predictive value of 91%, versus if you had a high pretest probability, the negative predictive value was only 38%. So they further derived this in order to develop this test as a negative or a rule-out test. So, for patients who have low or intermediate risk of lung malignancy, a negative classifier had a negative predictive value of 91%, and that moves about half of the patients from intermediate risk down to low risk. So we hypothesized that a negative test could reduce the burden of additional procedures. In other words, if I have a patient who has an intermediate risk for lung cancer, and I do a bronchoscopy and I don't find lung cancer, and I do a bronchial genomic classifier that is negative, then that shifts the risk of lung cancer in that patient down to 10% or less. And that may, in some individuals, allow us to justify doing radiographic follow-up and rather than doing additional invasive testing in order to diagnose what their nodule is. So, and then a positive test really had a poor positive predictive value of 40%. So if you have a positive test in this population, it doesn't really shift anything that you would do. So most individuals would go on to more invasive testing in order to diagnose a nodule that is intermediate risk. But in a negative test, we might be able to avoid some of those additional procedures. So we wanted to look at that and see if that would actually be the case, and to begin to address the possibility that the test could alter physician decisions. We did a decision impact study. So this decision impact survey was using case vignettes where that were taken from the AEGIS I and II cases. So these were 36 random cases, all that had an intermediate risk as determined by the individuals putting the patient into the study. So 36 individuals, we felt we had enough clinical information from those cases. They all had an intermediate risk, and then we showed those cases to 202 pulmonary physicians, and then we randomly showed them either with the classifier result or without the classifier result, and then the total decisions made in the study was 1,581. So this was an online survey, 202 pulmonary physicians, 36 random case reviews, and physicians were asked for their next recommendation. So the impact of a bronchial genomic classifier in clinical decision-making in patients undergoing diagnostic evaluation for lung cancer was the thing that we were looking for. And these are the results. So here on the left, these are individuals with an intermediate risk of lung cancer who were not shown the test results. So these were the cases, and the 202 physicians evaluated the case information, but they were not shown any of the results from the classifier. And they recommended bronchoscopy 15% of the time, transthoracic needle biopsy 31% of the time, or surgery 12% of the time. However, if we randomly showed them the negative bronchial genomic classifier, then we reduced by threefold the number of times that the physicians recommended any additional testing. And this was after they had been trained on the bronchial genomic classifier and shown the data from the New England Journal of Medicine. If we look at the intermediate risk positive bronchial genomic classifier, if they're not shown the test results, they recommended additional testing in about 50% of the patients. And if they were shown the test results of an intermediate or positive test, that result actually went up to 65%. And there are probably some reasons why that occurred. From our predictions before the study and by the operating characteristics of the test, we don't feel that a positive test in this population should influence or increase the number of invasive procedures, but it did in this particular case. So then what was done was additional clinical utility calculations. And for this study that was published in Chest, and Neil Vichani is the lead author on this one, the AEGIS subjects were reviewed. So these were all of the AEGIS subjects, 939 actually, if you combine all of the different groups. They found 222 who had a low to intermediate risk for lung cancer. And what they wanted to do then was to look at how often that may have been useful information in order to help determine whether or not patients had to go through additional diagnostic testing. I'm going to skip that slide. We're going to go to this one. So this shows in patients who had low risk as predetermined by their physician, 13 underwent invasive procedures for benign disease, and 2 underwent invasive procedures that ultimately found cancers, versus an increase or a larger proportion of those undergoing invasive procedures if they had a risk of 10 to 60%. If you look at all of the additional procedures that were done, there were a total of 18 additional procedures done in individuals with low risk, and a total of 81 done in individuals with intermediate risk. All right. So then, if you look a little bit further and start to look at the classifier, over here on the left panel in A, we have patients who do not have lung cancer. This is their pre-classifier risk. 84% or 84 had an intermediate probability, and 69 had a low probability. So patients without lung cancer, 84 had intermediate, 69 had low. Out of these individuals, the classifier was positive in 43 and negative in 41. So that means that in this group of patients with an intermediate risk of lung cancer, a negative classifier result reclassified 41 of those 84 individuals into a lower risk. In the ones where you begin with a low risk or a low probability of cancer, a positive test doesn't shift the risk, and a negative test shifts the risk to very low, and that occurred in 42. Then they looked at the patients without lung cancer who underwent additional procedures. So these are, again, this is all occurring in the AEGIS I and AEGIS II studies, and the investigators at the time did not have the results of the classifier. So pre-classifier, those who underwent additional procedures, 29 had intermediate probability, and when you apply the test to those, 17 had a positive result or no shift in their post-classifier result risk. 12 had a negative test, shifting them into a lower category of risk. And if you begin with the very low or the low probability individuals, 4 had no change, and 9 had a shift to a lower risk category, very low risk category. Now, if you look at the patients with cancer, so how does that function well? And the main thing to note here is that in the intermediate risk patients who received a classifier result, it correctly identified 29 of those individuals, but it incorrectly identified 4 individuals with who had cancer but were shifted to a lower risk category. And if you begin at the low risk probability, those individuals didn't change at all. So there were 153 patients with benign disease. 42 of those underwent additional procedures. The classifier was negative in 21 of those 42, meaning that they could potentially avoid 24 additional invasive procedures, 12 bronchoscopies, 3 transthoracic needle aspirations, and 9 surgeries. Out of 35 who were diagnosed with cancer, 4 had a negative classifier result, so the false negative rate is 11%, meaning that in this population of individuals, we need to continue follow-up with CT scanning or additional testing. So This gave rise to nasal brushings. I talked to you about the fact that the cells in the respiratory tract all have this field of injury from smoking, and this is true also for the nasal mucosa. So during AEGIS I and AEGIS II, when we were doing the bronchoscopies, we also collected cells from the nasal mucosa, and those were analyzed later. There were 375 subjects in the training set, 130 in the validation set. There was some statistically significant concordance between the gene expression between nasal and bronchial epithelium. However, it didn't operate quite as well in terms of the negative predictive value. So you could only get to a negative predictive value of 85, and this is just barely above what you would get for the clinical model. And the positive predictive value was no different. So this is not being offered as a test at this point in time. There might be more work to be done on it, but I don't know at this time. There's also a study that's ongoing that was reported in abstract form at the ATS meeting in 2017, and Anil Vichani is the lead author on this study as well. This is ongoing. It's a 30-gene classifier that's been reduced to 8 genes, and it's obtained by obtaining blood samples. So overall nodule size operated very well as a predictor, and if you combine the nodule size with the gene classifier, it improved the area under the curve to very close to an almost perfect AUC. So a lot more work has to be done on this test, however. This is not as many patients as would be wanted, and as I said, the study is ongoing and just reported in abstract form at this time. So before I get to that, I have another case study, but I'm going to go back and talk to you about the first one. So if you recall, that's an 81-year-old man with a left upper lobe nodule that's spiculated. He had been a smoker when he was in college, had not been smoking for the last 55 years, and he's enjoying retirement, and I asked what would people do. So should we biopsy that individual? Should we do a bronchoscopy? Should we do video-assisted thoracic surgery, empiric radiation therapy, or should we do radiographic follow-up? Ara or David, are there any numbers on that?
It looks like there were 2 votes for radiographic follow-up and 1 vote for navigational bronchoscopy with genomic analysis.
Okay, all right. So that's good. So and as I said before, I think you could make a case for any of those depending on the patient factors. So this was a gentleman who doesn't fall into the guidelines very well because he told me, I'm not going to get a test done. I'm enjoying what I'm doing, and I do want to know what it is, but I don't want to go through any bronchoscopy or biopsy or surgery or anything like that. So I said, all right, we can handle that probably, and I explained to him that there's a risk that we may not catch this early, and he was okay with that. And so I brought him back, and 3 months later it was growing a little bit, and he was okay with that. And 6 months later it was growing a little bit more, and he was okay with that. And 9 months later it was growing a little bit more, and at that point he said, okay, so now he would consider doing empiric radiation therapy, and so that's what we did. And he, with nodule growth over size and the appearance of the nodule, it's an extremely high probability that that's cancer, and I don't think in those circumstances that they necessarily need a biopsy. There can be other things that you can do. Sometimes the radiation oncologists want us to do the biopsies, and we're happy to do that. But in case-by-case evaluations, I think in certain cases it's appropriate to go forward with that. So now here's another case study. A 40-year-old female, lifelong non-smoker. She had had a chest X-ray performed because it was required for her to immigrate from the United States to Australia. She was going out there with her husband while he was doing additional training, and they found a 12 millimeter nodule in the left lower lobe. She had no known risk factors for cancers. Her CT was performed, and then she saw me in clinic. This is her CT showing this funny-looking nodule down here in her left lower lobe, and I think it's difficult in this situation to decide what you should do with an individual such as this. So Australia was not going to let her come unless we could say that this was very unlikely to be tuberculosis, and of course I would agree that it's very unlikely to be tuberculosis, and I could easily say that, but then the patient was also worried about the possibility that she could have lung cancer. After much discussion, we elected to do a bronchoscopy because there is an airway that's going out to this. Biopsies showed histoplasmosis organisms, and she went on to Australia. I think that a situation like this, however, would be ideal for a genomic classifier, especially one that could be simply obtained, like if we could do a blood test and show that the risk of lung cancer in her is extraordinarily low. She's young, she doesn't smoke, it's in the lower lobe. She has no family history of cancer. She has no other exposures. If you had a negative genomic classifier that you obtain by a blood test, I think you could completely avoid any other invasive testing, and that's where I would like to see this field move at some point. But it will probably be a few years before we get there. So that's anyway. I had a bit of a question there, but I forgot about that. But that's what we ended up doing. I would be interested to know if anybody wants to text in any questions, or if they have something different that they would have done with either of those cases. I'd be happy to hear it. So in conclusion, the burden of nodules is increasing. We're seeing more and more of them. Most of those nodules are benign. I think genomic indicators might be useful in risk stratification of suspicious nodules, but more work is needed for additional assessment of lung nodules in never smokers, because we're finding that on an increasing basis we're having to identify individuals or evaluate individuals with lung nodules who don't have a history of smoking but have some risk factors for cancers. So I believe that's it. Thank you very much for attending and listening to this. Happy to have any questions from David or Ara as they, if anybody has texted any in.
Yeah, we do actually. Thanks again, Dr. Ferguson, for really a comprehensive yet concise and efficient presentation. Highly enlightening on an important emerging topic. Looks like we have at least 2 questions from the audience, and then I have a couple too. I'll get things started as we wait for maybe a couple additional questions. Now, you mentioned that the classifier was validated for 17 genes. Is there a threshold value for considering a test positive? In other words, do all the genes have to be normal for an assignment of a negative classification?
So that's technology that is which is held is proprietary to some degree. There is a threshold, and that threshold was decided by doing multiple different strategy calculations on sensitivity and specificity and prevalence, and so they end up reporting out positive or negative based on what that threshold is. But I'm not privy to know that threshold.
Understood. Okay, we have a second question. As you mentioned earlier, you live in one of the dimorphic fungi belts out in the Midwest. We out here in California, of course, live in a different dimorphic fungus belt, namely coccidioidomycosis. For others around the country who are practicing in these regions, Dr. Hegde asks, how do you handle these nodules since you see so many of them? Do you alter your risk stratification in any way, or do you more textbook follow the literature?
Yeah, that's an interesting question, and I think that I think I'd answer it like this. So I think guidelines are fantastic, and we should all read them and know them and apply guidelines to the clinical practice. But as all of us can tell, clinical practice doesn't always match up with guidelines. So I can use them truly as just a guide, but I don't always follow them to the letter. And the reason that I don't always follow them to the letter is that when guidelines are developed, they're developed outside of the realm of sitting with a patient in the clinic. And so a lot of what I end up doing is back and forth with the patient in terms of discussion, looking at risks, looking at risks of histoplasmosis versus risk of cancer. And occasionally we see people from California that come back up here and we see the rare case of cocci in our clinics as well. But I think that if we put all that risk together and we look at the patient preferences and the patient factors, I think that we can often come to a conclusion about what is appropriate to do in those individuals. And so I do a lot of biopsies because there are a fair number of people in my clinic that are very worried about cancers, even if maybe they're kind of close to that 10% risk, and I really think that it's histoplasmosis. A well middle-aged individual is often fairly uncomfortable with that, and so I'll end up doing a fair number of biopsies. If I'm convinced that it's histoplasmosis, and I'm absolutely certain of it, I'll try and prove that. Maybe I can prove it with serum-based testing and urine-based testing, but that's a rarity that you can prove it that way in this population. So it may not be a very complete answer, but I do think that it's important that we consider the risk of histoplasmosis, the risk of cocci in with our patients, because that's probably the majority of what I see actually is histoplasmosis.
Excellent, understood. Another question. So, of course, the recommendation is to obtain the material during bronchoscopy. What if you're not able to reach the nodule, or you don't think you can actually get it? Do you still proceed with doing genomic analysis, even if you haven't obtained a biopsy specimen?
Yes, and we did. So there are certain number of procedures where I think pre-procedure that I'm going to be able to get to it and get a biopsy that's accurate, and I find during the procedure that there's some reason that I couldn't. And typically under those circumstances, I'll go ahead and I'll collect things like a brush or a lavage that's in the area, thinking that I might be able to pick up some cells, but not very confident of it. Again, I'm in the middle of the procedure when I find this out. And then I was also collecting the genomic classifier material, or the epithelial cells. And so the patients in the study underwent the bronchoscopy. Not all of them had pathology that was able to be identified or evaluated in that study.
Makes sense. Thank you. One final question, it looks like. I think this one's from Dave, actually. He asks, do we have enough data to utilize classifier information differently in non-smokers versus smokers? For example, if we suspect a specific type of cancer or cancers that are not associated with smoking?
Yeah, and we don't have enough data at this point in time. That's the one that many of us just really wish we would be able to come up with soon. There is a study that's ongoing that's going to be independent of smoking, and so hopefully within a couple of years we will have information where that kind of classifier can be applied. But at this point in time, we don't. And as you know, smoking rates are going down in the United States, and in a city like Madison, which is a relatively healthy city, the smoking rates are very low, and so we're seeing more and more patients that have never smoked, but they have some risks. So yeah, we would really like that to come along very soon.
Excellent, thank you. Looks like that's it for our questions. Once again, thank you very much, Dr. Ferguson, for your time and expertise. Before we go, I'm going to turn it back over to Dr. Shah for final announcement.
Great. Thank you, Dr. Ferguson, again, and of course, thank you, Ara. First of all, I want to alert everyone that the next upcoming webinar will be on Wednesday, August 8th. That will be Dr. Eric Fulch from the Massachusetts General Hospital. He'll be talking about procedural insights for diagnostic pleural biopsies. So please keep your eye out to your email announcements from the AABIP for that. And then the second one that you see on your screen is registration for the upcoming inaugural conference for the AABIP in Denver. We will be closing pretty soon, so we encourage everyone who is able to participate, please join us. We really anticipate a wonderful conference and session for all things related to interventional pulmonology and advanced diagnostic bronchoscopy. So with that, we want to thank all of you for joining us today, and thank you once again for a wonderful webinar session today.
Good night, everyone.